So a few things that we need to talk about so that you understand the terminology of clinical trial designs. And the first of which is the idea of what are the objectives or endpoints or outcomes of a trial. Now, these three words can be used interchangeably, and they all really mean the same thing. And what is the single aim that the investigators are trying to achieve through their clinical trial? And it's often called the primary endpoint or the primary outcome. When you design a clinical trial, you have to choose a single thing that you think is going to be changed by your medicine. So, for example, if I was developing a new cannabis-based medicine in pain, I might choose a particular pain rating as my primary endpoint. Or if I was developing a new cannabis-based medicine in inflammatory bowel disease, I might use something like the Crohn's disease activity index, which is the kind of measure of how bad Crohn's is. You have to choose a single thing that you think is going to be changed by your drug. And if you're successful in changing that thing, that is what you get your license for. So Epidiolex is licensed to reduce seizures in epilepsy because that was their primary endpoint. So there might be other things that the medicine does, but the seizure reduction was the primary endpoint. It's the thing that they get licensed for. It's also what you calculate your sample size on, and your sample size is basically a calculation of how many patients do I need to do this in order to determine statistically whether or not my drug will work. And it's really important that your primary outcome is clearly stated in any clinical trial. You need to say upfront what it is you think you're going to change. You can't just go into a clinical trial and measure a whole load of things and hope that something is changed, because that's called fishing in clinical trial design. There should be something that you know from all of your preclinical work is going to be changed. And that's your primary endpoint. If you do a clinical trial and your primary endpoint fails, so you don't see a significant change in that one thing, but you do see significant changes in other things in the trial, then the trial is deemed to have failed, because it's what happens to your primary endpoint that's most important. So you can measure other things. You can measure what are called your secondary or your tertiary endpoints. And this is usually to subsidize, get a bit more information, a bit more data on your patient population, and learn a little bit more about your drug. So if you were looking in a pain population, you might want to look at other quality of life measures, like are they sleeping better? Is their mood improved? Things like that. And these are called your secondary and your tertiary endpoints. Now, as I said, if you fail with the primary endpoint, it doesn't matter if you see significant changes with your secondary and tertiary endpoints. Your drug won't get approved if they weren't the primary endpoint. What you might do then is in your next trial actually make them your primary endpoint if you thought that was appropriate. But often with cannabis-based medicines, sometimes and often in pain trials, the primary endpoint of some kind of pain rating isn't always improved in these trials. But what you do see with cannabis-based medicines is that often quality of life measures like changes in stress and anxiety, depression, sleep, interactions with family and carers can be improved. And these are things that will have been measured as secondary and tertiary endpoints. So something that's really important in trial design is whether or not your trial is controlled or uncontrolled. And it's really important to know this when you're trying to judge the weight of evidence in a particular area, because a controlled trial gives you a much stronger confidence that a medicine is working than an uncontrolled trial or an observational trial. And unfortunately, in cannabis-based medicines, we do tend to have quite a lot of uncontrolled studies. And so you have to learn to take those with a pinch of salt, because yes, the data is important and it can tell you a signal that these medicines are working in a particular indication, but it's not a definitive answer. And if you want a definitive answer, then you need to design a controlled trial to investigate this. So a controlled trial is where you demonstrate the efficacy of your new treatment based on comparing the response in the treated group with that of a control group. And that control group either will get a placebo, which is basically the medicine but without the active ingredient, so it should look the same, if it should come in a capsule if that's what the medicine does, or it should be delivered the same way. So everything about the placebo should be identical but without having the actual medicine in it. Or it should be the standard treatment that you would normally get as a patient with this particular disorder. Now, this is the gold standard, because if you want to develop a new medicine in a particular area, what you have to prove is that your medicine is better than what we already have. There's no point in us producing more medicines if there's already something out there on the market that works, or if your new medicine doesn't work better than what's already out there. So it is a gold standard to compare against standard treatment of care. Now, sometimes what happens, and this is very common in cannabis-based trials, is you're adding onto standard care. So, for example, if you are in a pain trial, often these people are already on all of the pain medications that they can be on, and then in our trial we would be adding on a cannabis-based medicine on top of their standard care, or adding on placebo on top of their standard care. So that is often what happens in cannabis-based medicine clinical trials. We don't often look at cannabis-based medicines against current care. An uncontrolled trial, basically there is no control group, so you can't compare your data against another group that hasn't had the intervention that you are trying to investigate. Often it's because the assignment of the patients is beyond the control of the investigator, so it would be too difficult to actually divide people into two groups. And the important thing about uncontrolled trials is that they draw inferences about the possible effect of a treatment. As I said, it's not a definitive answer. And they do tend to overestimate the efficacy of a drug. Now, efficacy is the word that we use in pharmacology to mean effectiveness. So they do tend to overestimate how effective a drug is, and they usually tend to underestimate how much of a drug you need. So what is the effective dose? So they're valid data, but they're not definitive data, and they can make you think a drug is more effective at a lower dose. So I just want to give you a working example. First of all, just to mention why something called the placebo effect. So it's quite difficult in a controlled clinical trial to see an effect above that of the placebo, and that is because we are quite susceptible to being able to actually make changes in our own body and our own conditions through what's called the placebo effect. So when you enroll in a trial, whether you end up being on the new treatment group or the placebo group, because you are enrolled in a trial and because you believe that this drug might work or that you might be on a new treatment, you can actually change your physiology or your mental outlook on things. And even just being part of a clinical trial and the care that you get and the interactions that you get with healthcare professionals means that you can see an improvement in your condition. So basically what you have to think of is that everybody who enrolls in a clinical trial will often see an improvement in their condition whether or not they actually received the new treatment or the investigational product or placebo. And so that's why uncontrolled trials you always have to take with a little bit of a pinch of salt, because maybe those patients would have done better anyway regardless of the medicine. So it can produce a subjective perception of change, so you might just feel yourself that you're better, or it can cause an actual improvement in your condition. So for example, you would think that something like blood glucose isn't something that you can just change with the power of feeling a positive mental attitude, but actually even things like physical outcomes like your blood glucose level or your blood pressure can be changed by the placebo effect. So it can be a physical as well as a mental thing, although it is known that conditions that involve the central nervous system, pain conditions and psychiatric disorders are very susceptible to the placebo effect because there must be a psychological component to it. So you get quite significant improvements in people, patients with these disorders, even with placebo. And really this just demonstrates the importance of perception and the brain's role in both physical and mental health. But it's just something that you need to take into consideration when you are looking at data. You need to look at whether or not there was a control group, was it placebo, was it standard care, how much of the effect will have been through placebo effect. So just want to give an example of why this is really important and how you can kind of maybe misinterpret your data if you don't control for it properly. So imagine that you've just done a clinical trial and you were investigating drug A and you were looking to see whether or not it was effective at reducing pain. And you collect your data and you see that you get a 50% reduction in pain with drug A and you think, wow, this is brilliant. I have just found a really great new analgesic drug. Now, that's what would happen if you had done an uncontrolled study or an observational study. Now, what if you had done a controlled study and you had a placebo group, and actually the placebo group had a 30% improvement in pain, a 30% reduction in pain. So then actually what you're doing is you're looking at the difference between the placebo and drug A, and actually all that drug A did was cause an additional 20% reduction in pain. But actually that's not bad. You know, I would take a 20% reduction in pain if I had a chronic pain disorder. So, you know, you would still think, okay, my drug is good. What if you had compared it against another drug, a very effective analgesic, we'll call it drug B. And actually, in your study, drug B came up with a 60% reduction in pain. Now, suddenly you've gone from thinking, actually, my drug is great to, no, my drug isn't great because it causes a 10% less reduction in pain than standard care. So this is just to illustrate to you the importance of having control groups when you're studying a group, because without a control group, you, in this instance, you think that drug A was a wonderful drug, but actually maybe it's not, or maybe we just need to learn more about it through more research. So something else that's really important in understanding clinical trial design is this concept of randomization. So you'll often hear that something was a randomized control trial. And what this means is that there is a random allocation of your study participants to receive either one treatment or the other. So you have developed some kind of randomization process to assign participating subjects into one group or the other. And it's completely random. There is no way that you could have any bias in putting some types of patient into one group and some types of patient into another group. And after they're randomized, those groups of subjects are followed in exactly the same way. So let's say it's a placebo trial, your placebo patients will have the exact same treatment, the same number of visits, the same number of outcomes measured as those that are in the active treatment group. And this really means that you can eliminate there having been any kind of selection bias in choosing which participants went into which group. It also facilitates something which is called blinding, which I'm going to come to. And eventually what this means is that you can use statistics to determine the likelihood that any difference between those groups is not just because of chance. So that's why randomization is so important. So blinding, again, you may have heard of something as being a double-blind randomized control trial. What does that mean? Blinding is basically the procedure where one or more people in the research trial is kept unaware of their treatment assignment. So the people who are doing the study should not know who are the patients in the placebo group and who are the patients in the active treatment group. because that might affect how they treat those patients or how they measure the outcome measures in those patients. So you don't want to allow for any unconscious bias to creep into your data collection. So single blind usually means that the research participant, so the patient, is not told of their treatment assignment. Now, it's really important that the patient doesn't know whether or not they're getting placebo or active drug, because that could affect how they behave during the clinical trial. So if you knew you were on placebo, you might just go, well, I'm on placebo, so I'm going to change my behavior and exercise because I think that's going to help me, and this placebo isn't going to help me. Or if you knew you were on the active control group, you might suddenly start taking more care with your diet because you become more conscious of your health. So it's really important that the patient themselves doesn't know what they're getting. So if a study states that it's single blind, it means that the participant doesn't know what they're on. If it says that it's double blind, it means usually that basically nobody knows. So the patient doesn't know, but also the investigators don't know which patients are in which groups. But not just the investigators, anybody involved in the study. So it could be the nurses, it could be the doctors, it could be the study sponsor, so who has overall control of the trial, and even the data analysts won't know who is in which group. They will just say this is group A, this is group B, and they won't know which group got placebo and which group got active drug. And that's really, again, to make sure that no bias creeps into the conduct or the analysis of a trial. So if something is double blind, that's really your gold standard, that the trial has been conducted without anybody knowing who was on what, and any data that you get at the end shouldn't have been influenced by any kind of bias or confounding factors. So another thing that we need to consider when we're looking at clinical trial data is the concept of eligibility criteria, or sometimes this is called the inclusion and exclusion criteria. So what this is basically, how did we determine which patients we would enroll in this study? And then by understanding that, you can maybe determine in hindsight, did we use the right patients? Because sometimes we realize after we've done a study that maybe we didn't use the right patient population, and maybe we need to do this again, but in a different group. So it's determining exactly who the patients are with a particular disease. What stage of disease do you want to be trying to affect? Are you looking for people who have just been diagnosed? Are you looking for people with stable disease? Or are you looking for people who have more chronic or debilitating disease? All of these things you need to consider in advance. What's their clinical history? How long have they had the disease for? What other medications are they on? Do we need to control for that? What ages of participants are we going to take? Are we going to take males and females? Do we need to think about their genetic background? So there's a whole lot of thought that goes into choosing who are the correct patients to use in a potential clinical trial. And it is absolutely crucial to make sure that you're starting off with the right population to answer your question properly. And I don't think often that enough thought is put into this, and you can sometimes read a trial and realize the reason that trial failed was because they didn't use the right patient population. They used people who were too sick or not sick enough, or had something that meant that the answer that we got from that trial is not definitive and not conclusive. So when you're looking at a clinical trial, if you're trying to do some critical analysis of a clinical trial, the eligibility criteria, the patient population, is something that's really important to look at. So the gold standard for clinical research, and what we consider to be the best evidence that a new medicine works, is what's called the randomized controlled trial, or the RCT. And we've covered these concepts already. You start with a cohort of relevant patients and they are randomly assigned into either the treatment group or the control group. They have the exact same follow-up throughout the period, the same care, the same number of visits and interactions with healthcare professionals. And then at the end, it is valid to statistically compare their data to establish whether or not the drug has worked. And usually RCTs are double-blind, so nobody involved in the study or the investigators know who ended up in which group, again, so that we can really be confident that the data that we get at the end of the study is valid. So an RCT is really what we look for when we are looking at an evidence base for a particular indication. We want to know what RCTs have been done. Were they phase 2? Were they phase 3? So studies can be have different types of design. They can be either parallel group or crossover design, and that has different implications in the interpretation of the data. So parallel group is what we've kind of been talking about already, where you have various groups and they're randomly assigned at the beginning, and then they go through the study in parallel, which is why it's called a parallel groups design. And then everybody gets tested for the same outcomes at the end and then compared. And there can be, we've talked about it before in this previous slide, we talked about there just being 2 groups, but actually in a parallel group study you can have multiple groups. So your patients at the beginning could be assigned into 4 or 5 different groups, and that could be because you're comparing different drugs, or it could be because you're comparing different doses of the same drug against your placebo. And this is really probably your most typical type of clinical trial design, is a parallel group design. But you can also have what's called a crossover design, and it's slightly more complicated and does tend to take longer. But in a crossover design, you start off with a cohort of patients, and then you divide them randomly into your active group or your control group, and they go through the study design period with endpoints collected at the end. And then you have a washout period where nobody gets any medicine at all for a period of time that you have determined is appropriate. And then you swap over. So the people who were on the placebo group now becomes the active treatment group, and the people who were on the active treatment group now become the placebo group. You go through the same clinical trial period that you had in the first half of the study, and again measure your outcome measures at the end. And effectively this means that every person is their own control, because you can compare how I behave for the 2 months I was on placebo medicine compared to how I behaved when I was on the 2 months of the active medicine. And this actually gives you a really quite statistically strong outcome, because we are all so different, because humans are all so different in their physiology and their genetics and their behavior and how they respond to medicines. It really just gives you more strength in your statistics, and you can tend to use fewer people in this kind of design. But there are limitations of it. There are problems in that they're very long, they can be very expensive for that reason, and also you have to have a very stable disease, because if you have a disease which is kind of slowly deteriorating over time, then you have to also take that into consideration, which can make things more complicated. But that is what is called a crossover design.